Welcome to Turnpaugh Talks. Today we're blessed with the presence of Dr. Cindy West. We're going to discuss Cindy West and present her to our community of listeners. So without further ado, welcome Dr. West to the program.
Thank you.
So let's start by just introducing you, your background, how you kind of got here, the road that you took to get here, your previous experience, and what you're doing today.
Well, I have a little bit of a longer road, maybe. For 25 plus years, was a nephrologist, but that's specializing in kidney disease, hypertension, dialysis. I was a medical director of a dialysis facility. This was all out in western Pennsylvania, in the Pittsburgh area. So I trained in the Pittsburgh area, stayed there to set up practice.
Did you go to medical school out there?
I went to medical school at Jefferson in Philadelphia.
Okay.
And then I did my training, my internship and residency in Mercy Hospital in Pittsburgh, which is now a UPMC affiliate, and then my fellowship work at UPMC in Pittsburgh as well. So my groups that I joined were out in that area. So I was sort of hip deep in true allopathic medicine, traditional medicine, mainstream medicine for many years.
So you were a kidney doctor, and what kind of cases did you see when you were a kidney doctor?
Well, you see everything.
Okay.
I think one of the things that drew me to kidney disease as a specialty when I was a resident was I quickly realized that you really had to have a feel for and some knowledge of all aspects of internal medicine.
Because you're board certified in internal medicine.
I'm board certified in internal medicine and nephrology and hypertension.
Okay.
But when I was training, I remember thinking, I'm working very hard on all of these other subspecialties, and I don't want to leave here with blinders on and only focus on, one system. So I want to do something that's going to give me a kind of a requirement to have some flexibility to involve the other organ systems as they affect my kidney patients.
So would it be fair to say that a really good nephrologist or kidney doctor really has to understand and include the whole body physiology because it all is revolving around kidney function?
I think that's true of any subspecialist.
Okay, fair enough.
Although typically that's not typically the practice. And that's something that we frequently say, from the functional side, is that everybody has their silo of system that they're involving. And if it's not their system, then, you go on to another specialist. Put your blinders on. And it's not a heart problem, so go see the lung doctor. It's not a lung doctor, go see, whatever. And that was my personal approach, that I didn't want to go through all of that work just to kind of forget all of those other things that I had worked so hard on.
So that's kind of interesting, because being a nephrologist forced you into whole body medicine, or at least that was your goal, was to say, I can't neglect any part of the body because it's all going to have an impact to my nephrology patients. So
and
you kind of took a holistic view right from the get-go without even knowing.
Without even realizing it. And I would say even before I sort of transitioned out of doing that, when I would make rounds in the dialysis clinic, and that would be on a weekly basis, people that would come in for dialysis, our group would see them every week to kind of check on things and see how they were doing. And I always felt if that person sitting there on dialysis told me I have belly pain, or I'm short of breath, I have a cough, or, whatever, it was personally very hard for me to say, well, you're going to have to go see your family doctor for that, or you're going to have to go see GI for that, or whatever. And we would joke, okay, which hat am I going to wear today or with this patient? Am I going to wear the GI hat? Am I going to wear the cardiology hat? Am I going to be just the kidney specialist today? And that can be fairly demanding.
It sounds like, because these patients are
They're
Some of them are
complicated.
end stage.
Yes.
They're not
They're
like
at-
patients are going to have a
Exactly.
cough and recover tomorrow.
Right.
You don't get on dialysis because you're super healthy.
That's correct.
Okay.
And, so we would see those people. We would just manage some hypertension, some mild kidney disease. We would see transplant patients, prepare them for transplant, see them after transplant. And that was the outpatient side. The inpatient side, you saw the much more abrupt onset of kidney problems and what was causing that and how could you get that back on track.
So I imagine seeing patients that were pretty significantly ill, you have to have a pretty sharp saw, so to speak. You can't, there's no tremendous room for error, so you have to have your clinical acumen pretty tight.
Yeah, you do. You there's not too much leeway one way or the other because you could tip the apple cart pretty easily.
And if managing hypertension in a patient who's struggling, or a high blood pressure in a patient who's struggling with a lot of other problems, comorbidities or other problems, I would think that the average Joe Blow high blood pressure patient would be much easier to manage than the multifactorial
That was, yes.
So-
It would be nice to get somebody that just needed to have blood pressure managed.
Or as I say, sometimes you can do this stuff in your sleep, because if you can take the complicated case and make it look easy, imagine
Right.
what you can do for the fairly uncomplicated case that's pretty easy to manage.
Well, and the other side to that was what the other providers or specialists for those patients were doing for them impacted what was happening with their kidneys. So many times it was a balancing act, and going back to that other provider saying, hey, we got to come up with another solution here because I know what you're doing is good for, I don't know, their heart, but it's hurting my side. So we have to meet in the middle somewhere.
So really taking a multi-systems approach from day one.
Really from day one. And again, many people don't do that, or don't like to do that, don't want to do that, or not comfortable doing
They
that.
want to stay in their silo.
Yeah, that's no judgment on them, but that was just not me. And now that you point it out, I actually don't think I've recognized that before, but I did.
Well, that's why I'm here.
I just would say I think this is my job as
This is what I'm supposed to
this is
do.
what I'm supposed to do.
So how do you transition from pretty significant health problems, acute health problems, on dialysis, kidney specialist? How does that get you to where you are today?
It didn't at first,
Okay.
because no doctor goes to med school not with the goal of helping people, and I think the nature of medical training, for countless reasons that's a whole other conversation. You come out truly believing that you are making people better and you're helping people, and you certainly are. I mean, when you control their blood pressure, you're preventing their stroke. Great. But that involves an ever-increasing number of medications and complications which require medications. And so gradually, over the decades, after I was comfortable with what I was doing, I started to realize, wait a minute. And I would always be impressed when my patients I typically saw an older age group. I did not see children. And most people in their 20s don't come in with, those kinds of problems. Some, but that was a minority. So most of the people that I saw were older and would come in with an 8.5 by 11 sheet of paper of a list of medications. And it would just astound me. How could they take all of those? How could they remember to take all of those? How could they afford all of those, even, with insurance? And here I was saying, okay, you have to take more of this now. And at the end of the day, I knew where it was all going to go anyway.
Yeah.
Right?
These were end stage patients.
Right. Because by the time they got to me, they didn't get that way overnight. And by the time they were in my office, they have been sick for a long time or had medical issues for a long time. And there was, at some point, not much I could do to make that better. Could I stabilize it? Hopefully. Or could I just delay the progression, which was most common? But there was not much I was doing to make it better, which was a different realization from the way things were at the beginning when you really thought I'm making this better.
So you didn't really love managing finality or death.
Well, nobody likes managing.
Right. But I mean, so you weren't really getting people back to life.
I think what it was after a while, it was these people are miserable, and I'm frustrated that I can't. I know there must be something that can happen. This just can't be the way it is, but I didn't know what that was.
So there was a sense of, certainly I could do something to change this trajectory. I just don't know what it is.
Exactly.
Yeah, okay.
Yeah.
So then where's that epiphany or aha moment where you say, let me look for something else? What happens there? Or is there one? Or is it a gradual?
Well, there was for me.
Okay.
I don't know if there is for everyone. I still remember the day of walking from my office to the exam room to see another patient and just stopping and taking a deep breath and thinking, I'm going to have to say this same thing that I've said 8 times already today again. And I'm saying those same things over and over and over. I am seeing different faces with the same list of problems over and over and over. What's wrong with this? This isn't right. It shouldn't be this way.
And so do you remember what you were saying over and over and over again?
Oh, well, those were kidney patients. So okay. I was talking, about their blood pressure, about managing their phosphorus, and preparing them for needing dialysis and educating them as to what the steps were for them to need dialysis.
Okay, so then you have this moment, and you're like, I'm saying this for the 8th time today. I can't do this anymore.
I can't do this for the next 20 years.
Okay.
Or I don't. Can I? Yes, because at this point I don't have to think about it too much.
Do it in your sleep.
Do I want to? No, this is not okay.
So then what's the next step you take? So you realize that this is not okay in healthcare.
Yeah, this is not okay in healthcare. And it was, I don't know if it was one step or a lot of little steps. But I know I remember thinking, I sort of started doing experiments on the patients and sort of just questioning them a little bit. And I would start with the diabetics and look at their sugar and look at their sugar control levels.
Because many diabetics wind up in kidney clinics. Right?
And frankly, by the time they got to me, they were well on their way, right? And I would say, so what are your sugar's not well controlled, and the worse that becomes, the quicker your kidneys are going to give out. So what can we do to manage this sugar better? What are you eating? Did you go to diabetes education class? What did they teach you at diabetes education class? So I started to just be curious as to where did this break down, right? How are they coming to me with the list of problems, which I know none of us are going to fix at this point? That was truly the realization. We aren't fixing this at this point, in the sense of reversing it. So where did this system break down? And, even the most well-intentioned patient who thought they were doing everything right, in reality, because they didn't have guidance, weren't doing things right in the sense of improving their health, even the ones that wanted to. And the rest of them had no clue that they could.
So it's interesting. You're saying, I have a kidney patient because of a diabetes problem or a blood sugar problem. Mm-hmm. What can I do about the blood sugar? You would think that would be a fairly thought out process prior to you coming along.
Right.
And so you're at the end stage pathology, going back and saying, what can we do about your blood sugar? What is the system in place to teach you about blood sugar? And you're finding that most of your patients are unaware of even how to manage that because they think they have a kidney disease. Right. Or they knew they had a diabetes disease, but they didn't know how to manage it.
Right.
Okay.
And most of them also then, by virtue of that disease process, had heart disease as well. Okay,
so they have heart disease, so they have these other comorbidities. So then what do you're doing these experiments, like, let's play around.
It became fairly evident after a while that there was this huge knowledge gap, that from the doctor's side, we knew. I mean, there was knowledge as to what needed to be done to control sugar, what needed to be done for heart disease and whatnot, but somehow that wasn't getting to the patients. So I said, so if we know what's supposed to be done, why don't they know what's supposed to be done? And there was this Grand Canyon gap between that, between the two sides.
And why do you think that was?
I still haven't come to that conclusion.
Okay, fair enough.
I
but
don't
we have
know.
the knowledge.
Well,
We're
I'll
not
tell you
conveying
one
it.
thing.
We're not conveying it.
I'll tell you one thing. It's a time. It takes time to do that. And, you hear this, or at least when you're in the medical profession, you hear this all the time. You have, if you're a specialist, you have maybe 15 minutes to see a patient. If you're a primary care, you have less. You can't teach that kind of information in 15 minutes, right?
Yet that is going to change the entire trajectory of the patient's health and outcome.
It is.
Seems kind of monetizing healthcare in a way that says we're gonna squeeze what we can monetarily out of you without regard to how it's going to affect you long term.
Right.
I know it's kind of a cold and callous way to say it, but if you taught me, it's the old thing, give a man a fish, teach a man a fish type of a thing. So
I started to try to squeeze in just a little bit of education, each time, recognizing that, that was kind of a drop in the bucket and that the system had to change. Right. And I didn't.
But better to light one candle than to curse the darkness. Right?
True.
Right.
True. So that was that was a semi-epiphany, if you will, right? And then along with that, because I would do hospital work at the same time, I would start paying attention to what was, what were we presenting people with in the hospital. And, I'd round on a patient in the ICU who had just had a heart attack or just had open heart surgery and was now allowed to eat. And they would be given a tray of, roast beef, mashed potatoes, and gravy with some white bread and butter and, a canned fruit. And that wasn't a statement on the institution that I worked in. They're all the same. That's the way it goes.
So you just had a heart attack. Here's food that promotes having another heart attack.
And I'm sure my picture was on the middle of a dartboard somewhere in a kitchen somewhere because I would frequently call down and say, we can't do this.
Right.
But that was, spitting in the wind for the most part. That's the way it was. And it wasn't that particular hospital. It's kind of the way it was. It was all of them. And I said, so this is, and we know that the teaching time is right after some kind of event like that. So what are we teaching them?
Most captive audience, right? So
right.
I'm here. Audience. You got my attention.
You got
I just
my
had
attention
open heart
now.
surgery.
Just had something big happen, and here's my meal. So if they give that to me in the hospital, that must be okay to eat.
They surely know what they're doing.
They surely know what they're doing, right? So there was that, and all of these little pieces just started to add up until when I realized I can't do this for the next 20 years, started looking for how can I, just me, start to close this knowledge gap, right? And I would start to do that a little bit, like I said, just little snippets of information. But you start reading, you start Googling, and, I found actually lifestyle medicine. Because what do we know? Lifestyle is the basis for more than 85% of chronic disease.
Say that again for me slowly.
Lifestyle is the basis of 80 to 85% of chronic disease.
And yet, if I can go back, rewind, we don't take the time to educate the patients on lifestyle. As per, we're stuck in a specialist is 15 minutes, a primary care less. 85% of the problem is being not ignored, but not addressed.
Well, not effectively addressed.
Right, not effectively.
Do we tell people to stop smoking? Yes. Do we tell people you need to control your blood sugar? Yes. Do we tell them you need to exercise? Yes. But telling them and giving them the tools is two different things.
Okay. So as we go through this, it's kind of fascinating to me that 80 to 85% of health problems are lifestyle. You would think lifestyle would be the front poster child of healthcare.
Exactly.
Okay.
And then
so you find a lifestyle medicine something.
Yes, I found the American College of Lifestyle Medicine, which was a very, that was really, I think had only been in existence for a couple of years when I started getting interested in that. So I joined that group and started going to conferences and said, yes, somebody out there in medicine recognizes that there has to be a change, that this has to become, the primary focus, frankly, if we're going to decrease and reverse chronic disease. It's bankrupting the country, and to say nothing of what it's doing, down at the personal one-on-one level.
Right, bankrupting our own personal health.
Right.
So what is some of the concepts of lifestyle medicine? What is that?
I mean, they sound so elementary. You think there has to be a group that does this? I mean, we know this. But it's an organization which I can no longer actively participate just from time constraints. But we're really educating providers of all levels: doctors, nurses, nurse practitioners, dietitians, social workers, everybody, on the need for lifestyle exposure, intervention, education, how to go about that, giving you tools to do that. So that's, the conferences were both presenting the data as well as providing kind of some hands-on things that tools in your toolbox. Okay, and I know whenever I would come back from one of those conferences, everybody held their breath because it was, what is she going to do
Here's
now?
Dr. West coming back with something
Oh gosh,
about,
she
like,
came
we
back
should
from a
change how
conference.
we eat. Yeah.
Here we go.
Right.
And actually, I was in charge of a group of patients, so I could experiment a little bit.
On a little cohort.
I had my little cohort, and I was blessed with a very talented dietitian. And since we know how important food is, right? She and I were quite the team.
Perfect.
So
didn't you guys write a cookbook?
Well, it was funny how this came about. Fortunately, Allison gets all the credit for this. When we would round, and she and I rounded together on the dialysis patients, and that was, chair to chair, kind of looking at the numbers, looking at the stats that we needed to look at, and then talking to the patient. I mean, they have to live. Everybody has to live. You have to have a social life, all of those things. But how to do that within the constraints of what you needed to do to keep yourself from getting sick, again, knowledge gap. So we would, ask people, oh, what did you eat this weekend? Because you've retained an awful lot of fluid in a couple day span. So you had to have had more than the recommended amount of salt or something like that. I didn't do anything. And, you know why that is, but, it's like you say with your kids, I didn't do it. Well, I know you did.
The lamp's broken. Somebody
I know
broke
you
it.
did. So I said to Allison, you know what, we need to figure out a way for people to be able to do that and not hurt themselves at the same time. So we know they're going out to eat. We know they're going to fast food places. We need to come up with a way to give them some suggestions. When you're going to Arby's, what would be the best things on their menu that you could eat?
So these patients were telling you they didn't go out to eat, but you knew they did.
Well,
so they're not sharing with you. Probably either out of ignorance, they didn't think they did anything different, or out of fact that I don't want to be chastised.
I don't want to be chastised.
Yeah,
that was.
I want to live my life. Listen,
right.
I'm already sick. Can I at least get an Arby's?
Right.
Type of thing.
Exactly.
Yeah.
So that was how it started, and then it just snowballed from there. And we said, wait, if we're going to give them a list, why don't we do a book? So it wasn't exactly a cookbook, but it was an eating guide, and it was it was
how to eat on dialysis.
It was dialysis dining on the go. That's what we called it.
Dialysis dining on the go.
And
you said they used that across the country then.
We had a great, we had originally only intended it really for my group's practice.
Right.
But we talked to a few people, and it was really quite popular. Now, unfortunately, fast food places change, their menus change on a regular basis, and unless that was going to be our full-time job,
right, you weren't going to keep up with it.
You couldn't keep up with it. So,
but a concept that was well ahead of its time. Ahead of its time. Like, how do I eat healthy in today's environment?
Right.
Or today's health environment, not just today's environment.
Exactly.
For me. How do I eat healthy for me based on my
What
health
do I
condition?
do for me? Right.
Which includes some regular, everyday places to go.
Exactly.
I know you don't recommend Arby's.
I don't recommend Arby's.
Or nothing is any fast food. So it's a fast food thing.
Right.
It's not Arby's versus Wendy's or McDonald's. It's just those are not the healthiest
But the reality
places to go,
of it
but they were going to eat there.
and is
right.
People are going to eat there.
So if you're going to go, what are better choices to make?
What's the least damage you can do?
That's just such a simple concept. It's hard to believe nobody else came up with. You're going to make these choices, but how do you make them a little bit better? How do you make a little bit healthier choice when you say, because I want you to eat cardboard and tree bark. Well, I'm not going to do that, and nobody's talking to me about reality, so I'm going to go eat, beef tallow and lard because nobody's telling me that there's that huge chasm. Right. I don't know where to go from here to there.
Exactly.
Yeah.
So we did that. We would experiment with other, because you get scored as to how many of your patients meet certain thresholds of control of metabolic parameters. So we worked our way around doing that, and little did I know, we knew that inflammation was a detriment to general health, which was manifested by low body protein. And most of our patients had low body protein.
So inflammation facilitates low body protein.
Right. So it breaks down body protein.
And proteins are the bricks and sticks of your body.
Correct.
So inflammation drives breakdown of your infrastructure.
Exactly.
Okay. You knew that a long time ago.
I knew that a long time ago. Yeah. But why couldn't we get these protein levels up? So we started looking at what ways could we address inflammation. And so we would start taking a group of people and doing things like giving them an antimicrobial mouthwash to decrease the bacterial burden in the mouth, which we know, even in functional, is a driver of an unrecognized driver of chronic inflammation. And lo and behold, people who could never get their protein level up all of a sudden had near normal protein levels.
So somebody who has a loss of bricks and sticks and building blocks of their body, which causes systemic system breakdown, you had them use mouthwash, and it changed.
Yeah, it was unbelievable. We were even surprised.
What a simple concept. What a simple concept.
Yeah, but this was a team, and we, there was 2 members of the team. The rest of them sat and said, knock yourself out, whatever you want to try.
But did that spill over? Did your colleagues then say, I'm going to recommend mouthwash to my other patients? Yeah.
Right.
Yeah.
Right.
So that's interesting. And, we've often said in functional medicine, dentists really could be the chief primary care providers, because what's going on here in the mouth will parlay into many chronic diseases, from Alzheimer's to protein synthesis to gut issues. To all kinds of things. And so it starts in the mouth. And if you look at somebody that has poor oral hygiene, they probably have poor metabolic hygiene.
Oh, absolutely. Yeah. And a heavy inflammatory burden.
Totally inflamed. And then inflammation leads to breakdown of your proteins, your bricks and sticks. And we wonder why, when we've had that for a long period of time, we look old. We don't have any muscle tone and feel terrible.
And feel worn out.
Right.
Right.
So
there was that.
Yeah. So that, I'm starting to get the momentum of you making that colossal shift of kind of leaving industrial medicine.
Right. To, I always called it the bottom rung of the ladder. Lifestyle and lifestyle intervention is, I think, perceived from in the traditional model as you would the bottom rung of the ladder. Nobody needs to step on that bottom rung of the ladder. It's right near the ground. It's not an important rung because I can just take the next step up, and I'll be further up the ladder if I step over that bottom rung.
But that first rung is the first step. Without the first step, you can't take the second step.
Correct.
Right?
But when you climb a ladder, you probably start on the third step.
Right.
And medically speaking, the third step is medication. Or maybe the second step is medication. Okay. Third step might be a procedure. So you stepped right over lifestyle.
Which is 85% of
Which is 85% of the
problems.
problem. And if you do it right, you don't have to go to the second or third step.
Right.
So that was the next revelation in my journey.
Right? So then you're working in the Pittsburgh hospital system. And then what changed?
Well, this was then all part of the lifestyle.
Okay.
As I kept...
So you started to participate in it.
So I started to participate in it. And as part of that participation with the internet searching, this functional medicine thing kept coming up at the top of, the top site on my Google searches. And I would look at it and say, that's I have no idea what that is, but it just doesn't even sound legit.
A little woo-woo.
A little woo-woo. Click and that can't be right. And I would just keep going down. And, and after this happens for a long time, I thought, my God, what is this functional stuff? So I clicked on the site. It was an IFM, the
Institute of
Functional Medicine site, right? So I finally clicked on it and went around their website and thought, well, that makes sense. This is interesting. Okay. Sounds a lot like life. They promote lifestyle. I promote lifestyle. Okay. And I needed continuing ed credits, and I needed to go to a conference. So I said, maybe I'll go to one of these weekend conferences. I'll get credits for it. It's in Florida. Why not? So I'm going.
Sounds good to me.
Sounds good to me. Yeah. So I went to my first functional medicine teaching module, and I remember sitting there thinking, please don't stop talking. Please just keep telling me more. Feed me this information. Because I had dropped my jaw.
Wow.
And
re-energized you.
Everybody, when you go out for a break and everybody's milling around, you could just hear other people echoing what was in my head, which was, I want to do this. This makes so much sense. This is so much better than what I'm doing. I want to do this. And I never looked back.
Nice. Beautiful. So functional IFM has 6 modules, right? And then the AFMCP, which is Applied Functional Medicine and Family Practice. So you did all those and became board qualified. And through the IFM, you took all of their classes, which include like cardiometabolic and energy.
Right. And once you've done that, you then have access to all of the updates. So, I'm actually going through one of them again now to see what else. Because I think once you've done this for a while and you go back, you just glean more and more and more out of watching the updated ones.
You see it again for the first time.
You see it again for the first time, right.
So, yeah. So brilliant. So that leads you to functional medicine and then here. So once you go through the IFM training, you have it all figured out then, right? You have everything all figured out.
That is very much just like traditional. I mean, it all looks great on paper, and when somebody else is telling you about it, you go, oh, yeah. Right, I got it. Until the patient's sitting in front of you. And then it's like, wait a minute.
That's not how the book told me to do it.
That's not what the book told me.
Yeah.
Or if this patient isn't in the book.
So you come and work here at the office and you're seeing patients and you don't see kidney patients now. I guess you could.
Well, I could.
Yeah.
I mean.
What kind of patients do you see now?
Well, that's actually the beauty, I think, and what I try to bring to this practice is I can straddle both sides. I mean, you can't do traditional medicine for as long as I've done it and forget it.
Well, that's one of the beauties I know collaborating with you quite often is, can you put your, I can do this in my sleep, allopathic medicine spin on what's going on with this patient. So I have a patient who's chronically ill, they're suffering, and there's kidney involvement. They all have multi-system involvement, but sometimes it's progressed to, I don't want to divorce. Like, you didn't forget your allopathic training to go to functional training. You built on it.
And
right?
I tell my people here, it's not all bad.
Yeah.
But medicine is a good thing.
Right.
And let's not throw the baby out with the bathwater.
Right.
Right? Are there things about it that are broken? Yes. That's true of many things, but that doesn't mean that it's all broken. And sometimes you need medicine.
So you bring your incredible clinical acumen from decades of being a allopathic doctor in a hospital to here now doing functional medicine and combining the two. And again, so you see all kinds of conditions?
I see all kinds of conditions.
Such as?
I don't see kids.
Okay, right.
Kids aren't in my wheelhouse.
Kids are not in your wheelhouse.
Not in my medical wheelhouse.
Okay.
Let's put it that way.
But, so from adolescent on?
Yeah.
And do you see more like, what do you see? Do you see thyroid, or do you see more snotty noses?
I see gut. I see a lot of gut, a lot of autoimmune, a lot of thyroid, Lyme.
Lyme disease.
What else do we see? Sleep,
Stress.
endocrine hormone
Okay.
imbalance. But as we know from a functional standpoint, I see that in one. You can see that in one person.
Right. That's not 15 cases.
That's not 15
one case,
cases.
right?
That could be one case.
That's the multimodal, multi-systems, multi-professional. I have a cardiologist, a gastroenterologist, a neurologist, a nephrologist, a proctologist.
And you got to look at things a little differently. That is both the fascination and the challenge for me to do functional. You have to look at it from a different perspective. It's like going back to the science that you learned in med school. It's the applied science.
Right. Applied science.
It's the applied science.
I just love that
biochemistry.
I love that you have kind of figured out the allopathic side, right? Which you can't do, just like everything else, you can't do from a book. You had to get dirty in it. You had to got to go in and see the patient. You're never going to learn it from reading a book. You got to get your hands dirty, but you got your hands dirty, and then you figured out that pretty easily, and now you parlay or bring that over.
How easily, but I got it figured out.
Well, you got to figure it out.
Right.
But you did it very well at a high level for many decades, and then you came over to functional medicine. So now I'll kind of fast forward. We're doing our spring summit, April 21st, 25th, April 25th. There you go. April 25th and 26th. This year, it's our first annual spring summit. Hopefully we're doing it annually. You're speaking at it, and your topic is?
An overview of functional GI.
Functional GI, or gastrointestinal health.
Gastrointestinal health issues.
With, I'm imagining... But tell me, I'm excited to listen and sit there. I want to sit there and really take notes. But it starts with diet, right?
Starts with diet.
Yeah. It's kind of ironic. We have patients with Crohn's, ulcerative colitis, irritable bowel, and it's starting to change, but most of their gastroenterologists will say, well, it doesn't have anything to do with your diet.
Doesn't matter what you eat.
How can it not? If I have a really bad skin rash, how can it not matter how I scratch it? But yet I have an irritated stomach and gastrointestinal lining. It doesn't matter what I throw down there.
It doesn't matter what I eat.
So I can throw steel wool down there and it's not going to hurt it. Like, that doesn't make any sense, does it? No.
Right.
And as you said, inflammation drives a lot of this protein breakdown, tissue breakdown.
Chronic disease.
Is there anything to, say, a diet that's anti-inflammatory?
Oh, my gosh.
Yeah, right.
Yeah. I mean, inflammation is the bottom line of heart disease, bowel disease, autoimmune disease.
So if it's inflammatory mediated, as we've already established, and you've kind of proven in your nephrology practice, and you also saw the changes in diet playing a change in inflammation and protein breakdown, which is all chronic disease, wouldn't it make sense that that would be a first rung, but also a first rung that if you don't get on that rung, you're never going to get the problem
it's not going to
solved?
matter what you do in rungs 2 and 3,
Right.
because rung 1 hasn't been stepped on yet.
So what is a typical anti-inflammatory diet for you? Or is there one?
Well, I think there are guidelines.
Okay.
I think you.
So
have
let me just ask you this question, and sorry to interrupt you, is what shouldn't be consumed on it? What is inflammatory? I think there's a lot of information gap too. I think many providers, even allopathic providers, are saying reduce your inflammation intake. And again, me as the patient goes, great.
What's that mean?
What does that mean?
What does that mean?
Or where do I start again? I live in the world, right? So I got to go to my Christmas party. I got to go out Saturday night and play cards with my friends, or I'm going
on vacation.
On vacation. What does that mean? Because I don't want to eat cardboard every day. So what are inflammatory foods and what reduces inflammation?
So probably, aside from stepping into the gluten dairy war, which we step into all the time with both feet, probably I think the first thing that is simplest for anybody is to remove and reduce sugar.
Okay, so sugar. And
because
sugar,
what do we know? Sugar, the more sugar you consume, the more insulin your pancreas has to produce, the more fat deposition you have. So sugar to insulin, probably one of the key inflammatory pathways.
Okay, so sugar and insulin. So sugar, does that mean I should avoid fruits and vegetables?
No. Processed sugar.
Okay.
White sugar.
Okay.
Artificial corn syrup, artificial sweeteners.
Okay.
Except maybe stevia is still okay.
Okay.
But the fruits and vegetables, and that's what, people who say, I don't eat any carbs. I eat no carbs. I say, do you eat vegetables? Well, yeah. Well, okay, those are carbs. So that goes, in my history, decades back, because people would tell me they ate no carbs. And I asked if they ate vegetables. And I said, okay, so there's a fundamental issue right there.
We don't even know
what a carb is.
A vegetable is a carb.
Yeah, I don't even know what a carb is.
But for many, many years, ketogenic diets have changed a little bit. We said fats were terrible, but take your fish oil. Like, well, what does that mean? Like,
right.
Are all fats bad? Because fish oil's fat. So should I avoid that? Or fats? Same kind of with carbs. Refined sugar, high fructose corn syrup, your sodas.
Yeah.
They're bad.
Right.
But vegetables, not always bad.
Not always bad.
Right? So, and fruit's kind of in between.
Exactly. So that has to do with the fiber. And when you eliminate sugar or eliminate fruits, vegetables, you're not just eliminating a carb, you're eliminating incredible nutrient that are anti-inflammatory.
Right.
So, get rid of the sugar and go for... Everybody says I should eat more fruits and vegetables. I say, we probably all eat enough fruit. We love fruit.
Fruit's
would be
good.
The first
It's sweet.
thing we
It
get
tastes
sweet.
good.
It tastes good. And maybe go a little more for the vegetables.
Right. So, and where do grains fit in?
Well, grains are that can be a little controversial.
Okay. I don't want to stir up too much controversy.
Well, I don't want to stir up it, but that's there's the gluten grains and the non-gluten grains.
So
and
gluten,
the lectins in grains, and
so you brought up gluten. It's ironic. So I don't have celiac. Why should I avoid gluten?
well, there's allergy versus sensitivity, which is a big controversy in the traditional world too.
And gluten. If I don't eat gluten, what's my nutritional deficiency going to be?
There isn't one.
So you could give up gluten with no health consequences whatsoever to you. Now, if you gave up gluten and replaced it with white sugar, that's a different story. But giving up gluten carries no health consequence.
No.
So going gluten-free, although I've seen some ads, go gluten-free, your health is going to go suffer. There's no benefit, necessary need to gluten.
Well, there's certainly no benefit if eating it is causing an inflammatory response.
And there's a difference between I can't do it because I have celiac and gluten causes inflammation.
Right.
And inflammation reduces my ability to have proteins, which are my bricks and sticks, which keep me healthy. So there's a possibility that gluten is just inflammatory.
Correct.
And that can parlay into poor health.
Right. And it's at least worth that is worth a trial. A good.
Is that like a day or two?
No, that's more like a couple months.
Okay,
6-8
a couple
weeks.
months. So that's fair to say. If you want to do it for 6-8 months.
Yeah.
Okay.
6-8 weeks.
Oh, 6-8 weeks.
And
okay. 6-8
see
weeks.
how you feel.
Okay. Perfect.
And you got to notice the difference, right?
And so you coming from really hard, I'll call it hard pathology, and into hard I don't feel gooditis, which is like, so it's like a soft pathology, but you really don't feel good. Have you been able to use the same type of foundational lifestyle medicine and see, I know you shared with us you saw the changes in your nephrology patients. Do you see this type of changes in the functional med patients?
Oh, absolutely. Absolutely. And nothing is more gratifying than to have somebody come in after 6 weeks or 8 weeks and say, oh my gosh, I don't have any more joint pain. My headaches are gone. You know, is that a life or death thing? No, it's not going to kill you, but you're going to wish you're not going to have a quality
But
of
your
life.
quality of life, if I have constant joint pain every day,
exactly.
and you know, we know this because over-the-counter non-steroidal anti-inflammatories, Advils and Tylenols, they're just
the first or second most prescribed or utilized med.
And if you just changed what you ate, you might feel better.
You might not need it.
Right.
Right.
And that's just changing your diet. You've seen changes in like headaches and joint pain, which I imagine, does that change sleep patterns?
Absolutely.
And weight patterns?
And thinking process and energy. So you feel more like walking, which is, what do we know? Another part of lifestyle.
Right.
You feel like moving. You can move.
I guess so. If my body's inflamed all the time, I have a headache and my joints hurt, I'm not even engaging in life. I'm not moving, and I'm probably not in that fun to be around. So maybe I'm depressed.
Right.
So maybe I need to see the rheumatologist and the neurologist and the psychiatrist, or maybe I just need to eat a diet that's less inflammatory.
Less inflammatory.
And again, not theoretical, applicable. You've seen it. Yeah.
Oh,
you've seen it. And it doesn't mean, back to the Arby's conversation, it doesn't mean you have to go live on a farm and grow your own food, although you could.
You could.
But it's just these subtle changes.
Yeah, and it's awareness.
Yeah.
It's awareness of how your body reacts and how you respond. Everybody responds differently. Like you always say, you're an N of one. You know, you're the only you. Yeah. So how I react and how you react and how anybody else reacts is very personal, which brings in that whole aspect of personal approach too.
And so
is less cookie cutter.
When you do this lifestyle medicine, do you ever find, is there ever a time where patients actually need pharmacology or medications?
Sure.
Okay, so you haven't divorced yourself from that. No. So it's
and I tell people, if I think you need medicine and you're not opposed, then you're getting medicine.
But for you to say that, it's no longer your first rung.
Right.
Right. So if you say, I think you need a medication, it probably, for me, that would carry more weight. Here's somebody who's not using medicine as their first approach, but says I need medication. Maybe I ought to listen a little bit louder.
Yeah.
Right. So I think there are those people.
And, you always, here's the deal. You need the medicine now. Maybe this medicine we'll use it as a bridge.
Right.
Let's think of it as a bridge. Because what else do we know? Lifestyle and natural methods of doing this take time. This isn't 2 weeks.
Right.
This is
changing.
6 months, a year.
So I also know you've studied a fair amount of immunology since, so a little plug for Dr. Sam Yannick.
Dr. Sam Yannick.
Sam Yannick is a brilliant educator and has an entire program just to study the immune system. And so I know you've dove in pretty deep and heavy.
Well, I've said to Sam Yannick, when I was in med school and they would start talking immunology, my brain would kind of go flatline. I was like, whoa, I don't know what language you're talking there, but it's not going in. So I learned what I had to learn.
But there was no application to it.
But there was no application to it.
So why would I learn this stuff?
So Sam, I said to Sam, you have made me able to understand this, and that is a feat I never thought was possible.
Yeah.
Right?
Yeah,
So I actually, most of the time, can follow what he's saying and take what he's saying, as you know, in our conversations, and apply it to therapeutics for the patient.
The understanding of immunology gives you a basis for how to treat or support so many different cases, right? So you've dug in pretty deep to that. So that's more than a weekend seminar.
Oh, definitely. Yeah. That's an ongoing thing.
Yeah, it's an ongoing learning piece.
Right.
So.
Right. And again, that's another one of those. You go back and pull that up to listen to it again, just to say, let me see what I hear this time. Now that I have the lens of getting your hands dirty, you hear things differently.
Well, and that's interesting. You say getting your hands dirty. Many times I've had a conversation with Sam, and he'll say, here's what the research shows, but nothing is as powerful as a patient's outcome. Right. So he's like, here's what I'm learning in the ivory tower. Right. And here's what happens when you get your hands dirty. Right. And him being a clinician and an immunology teacher, he kind of sees both worlds. So.
Well, and that research ivory tower thing also is necessary. It's a benefit, but it's also quite the hindrance. We live in an age of, let's use our medical techniques based on what has been proven by the science.
Right.
But what do we also know? What we think has been proven 2 years from now is disproven. So I don't think you ever really want to have it all figured out. And when you come up with, I just sent you that article the other day, or yesterday, about the fact that diet improved, and what was it, Crohn's or ulcerative colitis? Inflammatory bowel disease.
Inflammatory bowel disease.
This was at a national gastrointestinal conference, and somebody presented research that when they changed a group of patients' diet, they had fewer symptoms from their inflammatory bowel disease.
So again,
we said,
eating
really?
Food changes your inflammation was something
They're
you proved.
Catching on.
Yeah, you proved to yourself and your patients decades ago.
Exactly. So if you're waiting for the randomized controlled trial when you're dealing with things like food, you're going to be waiting a really long time.
Or it reminds me of a colleague of ours, who I know you've lectured with, Dr. Neil Specter, who is a Lyme disease survivor. He's a brilliant researcher at Duke University, specializing in oncology and specifically breast cancer. And so he was tasked with finding new medications or interventions, I should say, for breast cancer. And on his travels, when he got sick with Lyme disease, and his colleagues said, "There's nothing wrong with you. You're lazy. You're stressed. You're whatever," and he said, "No, I really don't feel good." "Oh, you're just tired." He said, "I've run marathons and I can't walk up the steps now." "Well, there's nothing wrong with you. You must be depressed. It must be stress. It must be depression." And lo and behold, he had Lyme disease and needed a heart transplant.
Wow.
Now he's got a heart transplant. He wrote the book Gone in a Heartbeat. And now he's studying breast cancer, and he's finding that up to 80% of breast cancer has Bartonella in it. So a whole new way to look at this. And if we wait, I'm coming full circle on this random diatribe, but if we wait to say, hey, maybe we should look at an infection which drives breast cancer, that's going to help our children's children, but it's not going to help the breast cancer patient today. So we need to think a little bit outside the box and look at some of the case reports and case studies as opposed to the double-blind placebo-controlled studies.
Right.
It's not going to help our patient today. Sorry for the diatribe, but in my dysfunctional brain, it reminded me of that. Like, if we wait to see, does this really hold water that patients can have an infection that leads to cancer, that's not going to help this generation.
Exactly.
So
yeah, this is, for me, certainly a blend of both worlds. Functional is certainly detective work. Not that there isn't that aspect, but this is much more detective work and puzzle solving, which I like to do.
Yeah,
Dig in. And I guess even then, maybe the handwriting was on the wall. Right. I was always I remember having autoimmune patients. And they would say, I'd say, well, you're, one of the tests, your ANA, your autoimmune marker is high. how did I get that? And I'd say, yeah, we don't know. I mean, we don't know. And as I was saying, because at that time, I didn't know. And I'm not saying I know it all, but as I was saying it, I would think, this doesn't feel right to me, that I have to say, we don't know why you get this. It just happens sometimes.
But we treat it anyway.
We don't know why you get this or why people get this. It just happens sometime. And I'd be saying the words and thinking, this isn't right. I know this isn't right, but I don't know what else is there.
Well, coming back to your systems biology, as the nephrologist looking at other systems, but I found it interesting that there's really no autoimmunologist, right? So if you have Crohn's, you go to the gastroenterologist. But if you have MS, you go to the neurologist. But if you have Hashimoto's thyroiditis, you go to the endocrinologist. And so I've often thought, what are they...
What's the common pathway there?
Where's the common pathway between those silos? And and how many times do you have a type 1 diabetic, which is an autoimmune disease, who then has 2 or 3 or 4 other sequelae, autoimmune diseases, who are being treated by other silos, when the real problem is the immune system. So we don't really have an autoimmunologist, which I've kind of argued is the functional medicine doctor.
Perhaps.
Yeah. And you were kind of on that road early on. I want to see you have this pathology, but I know it involves these other systems.
Or that there's something here I don't know. At that point, I know there are pieces here I don't know.
Right.
Yeah.
So I'm sure we'll have many more talks, and we'll go deeper into specific subject matter. Maybe we'll have one on just mechanisms of high blood pressure and how to look at a lifestyle to maybe change that, or others. I'm sure that would be fascinating to me to learn more about that. Is there anything else you wanted to discuss on your introductory to patient population and community?
Nothing really to discuss. Just again, that this just, you got to be open. There's plenty of good about traditional medicine, but you got to when you're not getting results, you got to think outside the box. And if something inside you says, "Is there a better way to do this?" Maybe there is, and I think that way is found in the functional approach.
And again, coming full circle, decades of traditional allopathic medicine as your base for functional medicine, so not losing that tremendous knowledge base.
Oh gosh, no, no. Still pull from that every day. And actually, when I review labs, I think there are 2 phases in which I do that. Maybe kind of quickly in my head, but I look at them from my traditional hat on, and then I have to go look at them again and say, okay, with my functional hat on now, what does this mean?
Different pair of glasses.
Different pair of glasses on the same set of labs.
Wow, it was impressive.
So,
well, Dr. West, I am very grateful you came in today. Hopefully it was informative. I look forward to doing many more of these with you, and also really tuning into your Spring Summit lecture.
Okay,
Thanks
thank you.
so much.